A lot of the cases that we discussed earlier with Dr. Ginsberg's talk, sorry, you have to sit down, you have to pay attention.
I'm not going to sit down.
Okay.
I'm
A lot of the cases that we discussed earlier have some overlap with what I have prepared. So I'd like to kind of open this up to Dr. Ginsberg and the urologists and some of the residents in the room to discuss some issues here. So the first case that I want to talk about is the other way that I want to coach this is not everyone here is necessarily so into neurourology that this is what they see all the time, but these cases are ones that are going to end up on your clinic or in the emergency department. So this is a 70-year-old guy who was sent from a nursing home. He's a retired steelworker who had a stroke a few years ago, and pretty much he's nonverbal now in a nursing home. And has all the comorbidities. He's had his stroke, he's had multiple heart attacks, and of course he has a suprapubic tube in place. So who knows why the suprapubic tube was placed? And he ended up at the nursing home about 6 months ago with the suprapubic tube there, and who knows how long it's been there. And the reason that he is coming to your clinic is because he has leakage around the suprapubic tube and, of course, per urethra. They say they're exchanging the suprapubic tube almost weekly over the last few months, so that's become really bothersome. And everyone has seen this patient. And of course, oh yes, it's a 16 French suprapubic tube. They haven't upsized it to 24, but they've been going up on that volume in the balloon. So he was already put on anticholinergics, which is really good for an old demented guy in a nursing home. And that didn't help his incontinence per urethra. And so the kind of to throw out here to Dr. Ginsberg, how do you approach these guys? You've seen them all the time.
So first thing I do, make sure that they're keeping the back dependent, because that isn't always the case.
Hey David,
yes.
Can you just turn sideways?
Oh, does this mic?
We can't hear you.
Does this mic work?
Yeah, that's just for the camera.
I just make sure that the bag is dependent. As soon as you get patients are taking the bag, you see patients walk in with their bag on their belt, that really is not going to drink very well. So we do that. And the other thing is, we were talking about like the eroded urethra with big catheters. Once in my life, I've seen an eroded abdominal wall from a suprapubic tube. It was one of those like you type about you wish you take pictures. I took a picture. It was just wide open, like I guess extra view almost. It was crazy.
We have two of those right now, guys. Right? Residents see them in the emergency department all the time. Called about them. We had to put appliances over them, and
it's crazy.
Yeah.
So that's not so good either. So this is one of the ones in the patient that what are you going to do for this guy? If he was happy with the suprapubic tube, the suprapubic tube was working well before, and is not a guy you want to operate on and do anything else with all his other medical issues that he probably has along with his stroke. I think you consider what we talked to Mike about Botox his bladder. The other option is omega-3. If you want to add your background, and or you do combination therapy, though again you probably want to do your best to get off of muscarinic if you can.
Mike.
I think one of the other things to remember, when you use a Foley with 30 cc balloon, the catheter tip is longer. And so you can put 30 cc's in a regular 5, 10 ml balloon, it's better because it's a short tip. And in these males, if it's been a long tip, they may have already burrowed a hole or burrowed a cave within the bladder. And sometimes with polypoid cystitis, the islets are in that cave and it just naturally goes in. Subsequently, it doesn't drain, the bladder fills, they have bladder contraction, and will spasm and leak.
The deal with the cave, resighting the tube, of course trying a smaller catheter. I've had a couple, it looks fine, you scope them, it's in there, but you can just see it's buried in the cave. How do you work it?
Well, one option that Mike Kennelly and many other people in this room have started to use is a duet catheter, which has a second balloon, a 5 cc balloon on the tip of the catheter that protects that tip and hopefully would prevent the islets from getting sucked into that bullous edema cave that is potentially obstructing the drainage holes. So that's one theory that many of us have for these people that we can't get these chronic indwelling catheters out of, plus or minus the use of Botox for those types of patients. I don't have an example of the duet catheter on here, but we're starting to utilize that in select cases and hope to look at that further within our research group. So this guy had a flexible cystoscopy. You can assume he probably had a bullous edema, but specifically they were looking for BPH or stricture, none of which was there. But then he went on to urodynamics for this guy. So anyone want to make any comments on his urodynamic tracing? We've got 20 cc's down here first, 40 and 80.
That's another very happy bladder.
Very unhappy bladder. And fluoroscopy with this one. The catheter had to be in place because he was leaking out so much. So this was done with the Foley in 30 cc's in there. And you can see the filling phase, he still has a contracted amorphous bladder, not necessarily a Christmas tree bladder yet, but with his detrusor contraction, you have a really strong contraction, and he leaks out right there. And that was 20, 40, and 80 cc's. So early sensation, low functional capacity, multiple uninhibited detrusor contractions with really, really strong pressures. Incontinence per urethra and out that suprapubic tube tract, and specifically also no reflux in that case. So we've talked about many different options to go through parts of this. Anticholinergics are not a great option in this guy, and it's not going to probably work at all. And he's tried them. The beta-3 agonist, PTNS, you could technically put on this category to see if you could get any benefit out of it, mostly unlikely. What are any other thoughts for next steps?
Sara, what do you think about just the fact that you got a 30 cc balloon? I mean, you have about bladder spasms. Are you making that bladder better or worse by putting a big balloon?
I always think you're making it worse.
Yeah.
And that's what I tell people when I send their instructions back to the rehab hospital. Do not upsize the catheter and do not fill the balloon more than 10 cc's, because it's not there. My impression is that they're believing that the leakage out of the suprapubic tube tract or the urethra, it would be blocked if they put a bigger balloon to just kind of plug the hole. And I think we're just causing more of a detrusor overactivity by filling the bladder and never letting it actually empty completely. It's just a space filling.
I think he's going to do well with Botox in a regular size catheter with a regular size balloon, right?
Yeah, exactly. So one of the things for this guy, this ship already sailed. He already got a suprapubic tube. We talked a bit earlier this morning about different options for who we're going to choose suprapubic tubes. This guy obviously wouldn't be a very good, well, maybe in his nursing home before he got his suprapubic tube, he'd be good for CIC. And then one of the things that we haven't addressed is surveillance on these people. So what are people doing to follow these guys? Are we just sending them back to the nursing home and hope they live out their days and don't end up in an emergency department every other week with leakage or other complaints?
So we do our best to try to get folks to have their SP tube changed where they are, so not to come back and have us do it. But we'd like to also to see these patients back at least once a year, sometimes every 6 months if they can do their own changes. We do not do surveillance cystoscopies. We'll intervene if there are issues, whether it's recurring urinary tract infections, or hematuria, obviously.
Any upper tract imaging?
Depends on, I don't unless there are problems.
Yeah.
I think we're not going to change anything. We're doing upper tract imaging because I'm worried about hydro. These patients, usually not, you're not worried about that with the SB2.
Yeah.
So, I don't know if you guys do that.
I was gonna say, Sarah, what do you think the life expectancy is of this gentleman? Like, what's his 5-year survival?
Probably pretty limited. He's 70, already in nursing home, status post-stroke, pretty much nonverbal at this point.
I think
So it's pretty limited.
It's an important consideration when you talk about surveillance. And I agree with David that if this were like a 25-year-old spinal cord injury patient who had a suprapubic tube in it, very aggressive about looking at upper tract things over time, just because of the chance of, like I said, high-low or stones or things like that, and following these pressures. The chance that this gentleman will probably be impacted by upper tract problems within 5 years from a suprapubic tube, given all this other comorbidities, is probably pretty low. Just the cost of transfer of care of things, of trying to do the surveillance of it, I'm not sure that there's a high upside.
Mhm.
Can I ask you a question about that? A chronic suprapubic tube patient, neurogenic bladder, and they come in and with renal insufficiency and bilateral hydro. I mean, what is that about? I used to just say when I started, oh no, it's a high pressure bladder, it's not draining just right. But after doing a few urinary diversions on these patients, it seems like an actual fibrotic obstruction. If you dissect the ureter actually through the bladder wall, it's narrow physically.
What we were talking about last night, I think it's infection. I think that these patients get chronic cystitis, which then causes loss of compliance, which then causes upper tract changes. Because we were talking last night, the challenges, you put SB tubes in lots of patients, and most do pretty well, some don't, and you have the same injury, the same problem, with different bladder physiology. It's an unanswered question.
Do you guys have any other insight into that scenario, which seems intuitively like it shouldn't happen? I mean, you have a
If you look on the CAT scan, it's typically a very thickened bladder. I've not seen that occur with a thin-walled bladder. So, and I do think it is where it goes intravesical into the trigone, that's the aspect to it.
Right, but you got a thick bladder, but most neurogenic bladder patients with thickened bladder walls don't have a problem, right? So there's something else going on that we don't fully understand.
I think it's kind of an unanswered question.
Right, I mean, certainly there's something going on in that bladder, but, you know, it's like the urethra. Some people are just behaving differently for reasons that we so far can't figure out.
All right.
Okay, we're
Thank you
gonna
very much.
move on to the next talk.